Okay, so when we talk about mechanical methods, we all often think about intermittent pneumatic compression, but it also comprises the graduated compression stockings, and they come in a variety of length. They can be either thigh or knee length, and there's even a type of IPC which is the foot pump compression that compresses the foot sole. Now, how do they work? Basically, they apply a graduated or an intermittent compression that is going to increase venous blood flow, and this is going to reduce venous stasis. And this compression is always distally to proximally, so you have to think it's like if we're milking the patient, but inversely. So next slide, please. Now, before I present you the evidence of these mechanical methods, I first have to explain you how the trials were performed and their limitations. Now, they're always randomized controlled trials that we're going to present today, and we're going to see the results. Patients are allocated to a treatment, a mechanical device, and at the end of the treatment, they are screened for venous thrombosis. But what you have to understand is that most of these thromboses are asymptomatic distal venous thrombosis that's spontaneously resolve without prophylaxis. So the clinical meaningfulness of these results are questionable. For a strong recommendation, we need to demonstrate a reduction of clinical events, for example, pulmonary embolism. The second limitation is the poor methodological quality of these trials, and the third is that there are, like we saw with aspirin, old studies, and are the result generalizable to today's practice? Well, that is a question. Okay, now let's have a look at the stockings. Now, stockings, compared to nothing, reduce asymptomatic DVTs, but we don't know if they reduce some symptomatic events such as PE. Compared to heparin, they show a similar efficacy, but they were not tested in high-risk surgery such as hip or knee arthroplasty. Therefore, the SR guidelines recommend to not use routinely stockings alone. So we have to ditch the stockings. Now, what about IPC? They also reduce DVTs, but again, we don't know if they reduce pulmonary embolism. Compares to stockings, they show a higher efficacy for DVT, but again, no idea on symptomatic events such as PE. Now, we mustn't be too negative with these trials, and we still object. We see that there is a reduction for deep venous thrombosis with these mechanical methods, and therefore, if we can't use chemoprophylaxis, well then the guidelines suggest to use these treatments and prefer IPC over stockings. Now, can we improve chemoprophylaxis with mechanical prophylaxis? Can we add more efficacy? Well, yes. Both stockings and IPC reduce deep venous thrombosis, but only IPC added to chemoprophylaxis reduced pulmonary embolism. But this, we have to be careful, this was only demonstrated in one single trial that was not performed in orthopedic surgery. So the guidelines, because we don't have high-level evidence, recommend not to use routinely combined therapy and to propose it to only to very high-risk patients. Now, so the question is, should we use mechanical methods in orthopedic surgery? We saw that we can't give any strong recommendations, and therefore my take-home message has to account for French cultural preferences and values, and therefore the GIHP recommends IPC, but this will only concern a minority of patients. The big message is no more stockings, and therefore most of our patients will go barefoot.
Thank you very much, Paul, for this nice overview of mechanical prophylaxis. But in fact, you mainly discuss mechanical prophylaxis in the context of general surgery. And if we want to focus a little bit more on orthopedic surgery, and especially, if we go back, on total knee or total hip replacement surgery, what's your point of view for the place of mechanical thromboprophylaxis? And especially, how can we choose between mechanical prophylaxis or antithrombotic drugs, or both?
Well, that's a tough question. I don't have the answer, but I've got a slide and I can show it to you. That's, if we can go back, it's the next one. There we are. So here is a meta-analysis that compares IPC to chemoprophylaxis in hip or knee arthroplasty, and as the studies were performed over a huge range of years, the chemoprophylactic drug used has changed over time. So in the old studies, which are here, we see that IPC is more efficient to reduce DVT than the aspirin that Pierre told us was less effective than the new anticoagulants. And we don't see any difference on symptomatic events. Now, when we compare IPC to stronger chemoprophylaxis, such as heparin or low molecular weight heparin or vitamin K antagonist, we don't see any difference for the thrombotic events. There is, however, a trend in favor of low molecular weight heparin, but of course we observe, and what is very interesting, a huge reduction in favor of IPC for major bleeding. So it's a balance between, should we favor the reduction of the risk of major bleeding and choose IPC, or should we favor the reduction in VTE and therefore choose an anticoagulant? And because we don't have strong recommendation, we don't have high-level evidence, I should say we really don't have high-level evidence, we can't propose one over the other, and therefore the recent American guidelines suggest using one over the other, and then it's really a decision that will be based on the patient's risk factors.
Okay, so this is a good explanation of why you propose mechanical prophylaxis mainly for patients with high bleeding risk and also for patients with high thrombotic risk, and in this case in combination with antithrombotic drugs. But the question after that is, how do you define high bleeding risk and how define high thrombotic risk? Because I suppose that, for example, trauma patients will be included in the first category, but could you give any other options?
Well, the problem is that, and you know, when you, I imagine when you write the guidelines, when people do these guidelines, they sort of they come and they say they give a recommendation, and then there's this sentence that says, well, you give it to very high risk patients, and then you say, okay, but what's a very high risk patient? Well, a very high risk patient for VTE is a patient with malignant disease, or has already had thrombosis, or has a severe thrombophilia condition. And then there are other less important risk factors, but I think Pierre-Marie, you're going to talk about this later on. And but what I want to point out is that this strategy of choosing depending on the risk factors of the patients in orthopedic patients has never been assessed. So it's sort of we can suggest choosing based on the risk factors, but we don't have any trials that demonstrate that this is it has an efficacy, it's pertinent.
Okay, so with no data, what is your advice regarding the duration of the prescription of mechanical prophylaxis? If we consider for example, patients with high bleeding risk. So at the beginning on the post-operative period or immediately after trauma, you will propose, I suppose, mechanical prophylaxis alone, and then you will propose a combination of mechanical prophylaxis and antithrombotic drugs, but for how long?
Well, again, thanks for the question, because we have trials that have compared the duration of prophylaxis, short versus extended prophylaxis with anticoagulants. We don't have any randomized trials that have compared IPC short duration versus IPC long duration. So, with a strong level of evidence, I can't answer to your question. The only thing that the first thing is that IPC was only given in the trials while the patients stayed in the hospital. They didn't have the IPC when they went back when they went home back. So the duration, of course, like Pierre showed us, the duration of that the patient stayed at the hospital varied in time. So we have some trials where patient had it at IPC for 2 weeks, and then they had IPC for 7 days. And when we look at the efficacy of IPC, there is no evidence to show that a duration of 2 weeks was more efficient than 4 or 5 days. So that's the first thing. So probably 4 days of IPC is sufficient, and then we could switch to another treatment. For example, I don't know, aspirin or another chemoprophylaxis. The other thing too is that we know from trials with anticoagulants that the bleeding risk is really increased during the first week. Then after, the hazard of bleeding really reduced back to normal after 7 days, 10 days. So it's somewhere giving in a patient at high risk of bleeding in the first postoperative days, the correct thing would be to give an IPC, and then we could go on with an anticoagulant if it's possible after a week. I don't know if I've answered the...
Yeah, perfect. I have a very short question to finish. You presented a lot of new information, and if I understand well, there is no more place for compression stockings. So no socks, no stocks, no ties, nothing more. Is that true?
Well, yes, except for the patient that suffers from venous insufficiency, chronic venous insufficiency, and feels better with his stockings, then you can leave him or leave her with the stockings. The patient will appreciate, but not for a reduction of VTEs. Ditch the stockings.
Okay. Thank you very much, Paul.